Good morning and welcome to Global Healthcast, brought to you by Global Health Press. In this podcast series, once a week we bring to you news and views about public health, vaccines, infectious diseases, and vaccination. I am Joe Schmitt, and with me is Dr. Melvin Sanicas. Good morning, Melvin. Good morning to Switzerland.
Good morning, Professor Schmitt, and good afternoon, good morning, or good evening to those who are watching us or listening to us today.
This is our topic today. CDC confirms severe H5N1 in a U.S. patient. Wisconsin reports a presumptive avian flu in a poultry worker. And Melvin will summarize what you can do to not be too scared about H5. I will cover the use of glucocorticoids in community-acquired pneumonia. And then we will review non-pharmaceutical interventions in households against influenza transmission. Speak of hand washing and masks. And finally, I will have a more principled paper reviewing real-world evidence if you could use it for decision-making, yes or no. And having said this, Melvin, the floor is yours for the first severe H5N1 case in an American patient.
Yes. So a patient has been hospitalized with a severe case of avian influenza A, H5N1, in Louisiana. And this is the first instance of severe illness linked to the virus in the United States. The case was confirmed by the CDC last Friday. And since April 2024, there have been a total of 61 reported human cases of H5 bird flu reported in the US. And this is the first severe case. So partial viral genome data of the H5N1 avian flu virus that infected this patient indicates the virus belongs to the D1.1 genotype related to the other D1.1 viruses recently detected in wild birds and poultry in the US and in recent human cases in different areas like British Columbia, Canada, and the Washington state. And this H5N1 bird flu genotype is different than the B3.13 genotype detected in dairy cows, sporadic human cases in multiple states, and some poultry outbreaks in the United States. And additional genomic sequencing and efforts to isolate virus from the clinical specimens from the patients are underway at the CDC. So they are on top of things. They are looking at the exposure of this patient and who are the potential other people that has been exposed to this person who has been infected. And really, this case underscores that in addition to affected commercial poultry and dairy operations, wild birds and backyard flocks also can be source of exposure. And people with work or recreational exposure to infected animals are at a higher risk of infection and should follow the recommended precautions when around animals that are infected or potentially infected with H5N1 avian flu virus.
Very interesting. Thanks for sharing this information with us. Again, this is an animal to human transmission. Again, it is poultry to human, correct? That is the story, but it was severe. That is the news. Yep. It was not a mild case as we've seen it before, but it was a severe case.
Yep, correct.
So we continue to worry about H5N1 as we did in a couple of podcasts in the past. And here you have a second story on Wisconsin and avian flu.
Yes. So the Wisconsin Department of Health Service detected the first presumptive positive human case of H5N1 influenza A in one of the counties. And this case follows an infected flock of commercial poultry identified in that county. The person had exposure to the infected flock, and this was identified through the testing at the Wisconsin State Lab of Hygiene. So this H5N1 highly pathogenic avian influenza, or HPAI, virus has continued to circulate in both wild and domestic birds in North America since December 2021. And they are highly contagious and often fatal to domestic poultry. And the disease can spread from infected birds to people by contact with infected birds, and also equipment, droppings, or clothing worn by anyone working with animals. This virus does not spread easily from animals to people, and people who have gotten sick with the bird flu have been in direct contact with infected animals. Again, this is what we're trying to say here, that these cases are people who have been in contact with infected animals, or animals that didn't look infected but were actually eventually found to be infected.
So if you look at this animal farm, one of the messages there is if one of the chicken here is infected, all others will be infected sooner or later.
Yes, that's
They
right.
live together so close, so there is no way around the assumption. Actually, it is a fact that they will all get infected. They
That's right.
probably get infected through people bringing it in or through other birds bringing it in from the outside, right?
Yes.
I mean, there must be a way to get it in, right?
Most probably some birds flying into that poultry
Yeah,
area. Yeah.
yeah. Very interesting, very scary as well. And just as a reminder, 95% of influenza vaccine capacity, production capacity, is produced from fertilized hen eggs. And if there is an avian flu outbreak, the production capacity will be very low because there will be no hen eggs, right? You need fertilized hen eggs, millions of them. And if these chicken die, there is no product. So we have to rely on other methods. But anyway, this is scary, but we don't need to be too afraid, or am I wrong? What can
Yes,
we
we don't
do?
need to be too afraid. In the next slide, we'll tell you what to do. Yes.
Yeah,
So I think the message that we wanted to say here is that the best prevention is to avoid exposure. I think that's pretty clear, right? What we know so far now is it is safe to eat eggs, poultry, and meat that has been fully cooked. Pasteurized milk and milk products are also safe to eat and drink. General precautions should always be taken when handling any raw meat, including raw eggs, to avoid possibly spreading germs. So wash hands and surfaces before and after food preparation. Avoid using the same utensils on raw meat as on the other foods. And cooking raw meat thoroughly. They are really important. And if you have returned from a country affected by bird flu and feel unwell, it is important to seek medical advice as soon as you can. So I think these are simple ways to uh, remember that if you are in an area that is known to be affected by bird flu, you just have to be careful that you are not exposed, right? You should avoid direct contact with wild birds or animals infected or suspected to be infected. And if you must have direct close contact with infected or potentially infected birds because of maybe your work, you have to wear the proper PPE or personal protective equipment.
very interesting. Is this based on WHO recommendations or is this general hygiene rules?
This is CDC. This is the CDC recommendations as well. Yeah.
Okay. Look, cooking raw meat thoroughly, having lived in the United States and going there on a more or less regular basis, usually the first thing when you order a steak is how would you like it, rare or medium?
And
That
I
is
think
the only question.
most people order medium rare, right?
Right, right. So this is not CDC recommendation, although I guess more than 100 herds cattle herds are affected by H5N1, right? And the virus is even in the milk. So yeah, cook raw meat thoroughly. I guess it's a very good advice. Yeah. Very good. Thank you, Melvin. I think this is very good advice, everyone around the globe. And there are other avian flu viruses circulating, for example, in Asia, with many cases, and we had summarized that in the past. Let's leave bird flu and we go to community-acquired pneumonia. And what happens here is that if you are severely ill from pneumonia, and just as a reminder, 12.5% of people die from pneumococcal pneumonia if they are above 60. So it's a severe disease. And before you go to ICU or when you go to ICU, your physician may want to give you glucocorticoids. But there is no very good data to show you that this is beneficial. And here we have an article on the real-world use of systemic glucocorticoids in patients hospitalized with community-acquired pneumonia outside the intensive care unit. It was a retrospective study with with more than 11,000 cases, hospitalized cases. They did not have chronic pulmonary disease. The study is from Canada, and they looked at physician variation in the use of glucocorticoids. There are some physicians who do it always, some do it never, and then there are those in between who give it to a certain subset of patients. Now here, they found that glucocorticoids were prescribed in 11% of these 11,588 patients, and that there was a little bit of an increase from 2010 to 2020. And leaving out the details, the one major finding was that patients treated with glucocorticoids had higher rates of in-hospital mortality. So this is bad news, right? Now, the big question to me is this higher rate of in-hospital mortality. Is this because these patients were sicker to begin with, or is this because of glucocorticoids kill you? That we don't know. That I did not really find out. Glucocorticoids were not associated with ICU admission, hospital length of stay, or 30-day readmission. So the big question is this a real finding, or is this due to any confounding from a real-world evidence study looking retrospectively at a cohort of patients that had been admitted to hospitals in Canada? I think this is very important because pneumonia is quite common. Pneumonia, specifically in the elderly and in the very young, is a common disease with a high incidence, and I am puzzled why we don't have better data. I didn't remember it from my intensive care time some decades ago, but I'm wondering why we still don't have any good data on this. And I think this should be one of the first priorities, and actually health insurance companies or even governments should make sure we get that type of data from a double-blind randomized study, right? It is so important. Look, if people still use it, and this one study will not prevent people using glucocorticoids in patients with community-acquired pneumonia hospitalized somewhere. So we really should know if there is an adverse effect resulting in the death, and we should have a double-blind randomized study on that. Melvin, any views from your point? Melvin?
I think in reality, Professor, the ICU physicians really, even though you have recommendations, they have some personal, let's say, guidances, right? They really look at the different cases, and even though you have studies saying that it works or studies saying that it does not work, in the end, they still really personalize the way they manage patients in the ICU. That's what I'm saying.
Yeah. I mean, I guess in the end, it's a personal preference to the attending physician or to the admitting physician or to the caring physician, whatever the country is and whatever the decision maker is here. But in the end, we need a study to show it works or it does not work, or it's dangerous or it's not dangerous, right?
Yep.
I'm puzzled. And we have quite a few examples in medicine where we don't have good randomized controlled data or any data to guide us with best treatment options. So this is a shame, and this is one of them, I think.
Yep.
Yeah. Melvin, I have another study, and that has to do with non-pharmaceutical intervention in household transmissions. You and I, we had always promoted hand washing, masks, and hygiene rules to be followed during COVID to make sure that you don't transmit the disease to others or that you are not infected by others. Now, this is a study Actually, it is a systematic review to look for the evidence if in a household setting, the wearing of masks and hand washing reduces the transmission of the influenza virus. They found 9 non-pharmaceutical intervention studies for evidence review, and they looked at that in a little bit more detail. And without going into the methodology in some detail, the conclusion is limited evidence indicates that within household measures may likely be effective only when implemented before or as soon as possible after symptom onset in an infected case. So it only works early on when somebody in the household gets infected. Improving the evidence base for NPI in households and elsewhere is continuing priority. So again, we need more evidence, but on this one, I want to show you data. And what you see here on the left side is the different studies, and here you see the risk ratio. So you see overall in the black box down here, it is overlapping the one. So, you know, we don't know if there is an effect or not. And down here, if you look for hand hygiene and also wearing mask, again, there is no effect in all the studies. The 95% confidence intervals even are overlapping here or here. They are overlapping. I'm not sure if this is just below 1 or above 1 or reaching the 1, that I don't know. But anyway, this is really not really good evidence that this is working. So Melvin, were we wrong all the time recommending hand washing and wearing masks for COVID in the past?
I think we have to take note that this is actually about households, right? So that changes the context of the study. And household is different from hospital setting, is different from the broader community setting. And so, you know, we just have to take note of that when we look at the study.
I guess what you want to say is that in a household, as long as everybody is well, people are wearing their masks and washing their hands frequently. But then when somebody gets sick, it may be too late to start wearing your mask. You are infected already, right? That is one of the findings from the study. It would support this, right? I guess wearing, I mean, here in our household, I wouldn't wear a mask all day. I mean, I can hardly imagine doing this, or washing hands every time I leave my office. I cannot imagine doing this. But exactly that probably would be helpful, right? That would be effective. And that's a different situation than working in a hospital where the organism is around you all the time and the recommendation is to wear the mask all the time. Yeah, I think I agree with you. It has to do with the household setting, right?
Yep.
Last piece is on real-world evidence, and I just covered the one study where I said this is an observational study. And an observational study is really difficult to interpret. It may or may not be that glucocorticoids kill you if you have pneumonia, community-acquired pneumonia, and you make it to the hospital. And here, what you see here from a recent publication, actually from this week, you see that only randomized clinical trials, they are proof of concept. They tell you the intervention works. But it may well be that the way the study is designed, it doesn't apply to people out there in a normal setting. They may not take their medications every day. They may be different from the study people, from the study subjects. So many, many reasons why randomized controlled trials don't tell you much about what happens in real life. And on the other side, the studies, cohort studies, case control, case series, all that has one big problem, and that is confounding. So we don't know if this is really, or if the intervention is really working, because the assignment to treatment group or non-treatment group is not blinded and is not at random. So we never know if cases and controls were really similar. It may well be that those with more severe disease have a higher likelihood of getting the study intervention. And this is a little bit the crux here. And again, this is nicely depicted here. Decreasing, the quality of evidence is very high up here, and it is very low down here, right? The big advantage of the observational studies in yellow, green, and blue, they have a high external validity. It is externally valid because this is real world data. Whereas the internal validity, again, confounding and bias, this is comparatively low. So this is a little bit the background, and the paper here would like to focus on using real world evidence alongside with proof of concept studies, providing there is high confidence in the quality of the study. And in the end, they say there is a low confidence if bias and confounding is not addressed, if there are inconsistencies, indirectness, imprecision, publication bias. But the confidence may be higher if there is assessment of confounding, if there are large population size and a big size of effect and a dose-response relationship. This raises confidence. And in the paper, they finally say you can have high confidence, moderate, low, or very low to the real-world publication. I would say for decision-making, you have to say, I recommend something, or I do not recommend it. It is a yes or no answer. It is not an answer, perhaps, right? You cannot say, I give the moderate recommendation to get vaccinated. You either recommend it or you don't recommend it, so it's a yes or no. And this is why I only use high-quality real-world evidence studies. That's it. That would be my recommendation. And again, for the study that I showed you on the use of glucocorticoids, it is retrospective. Confounding has not been addressed in a way that I would have liked to see it. Many, many other things. So I think this study I would not take too serious, and that mortality was increased. That is an initial finding, but this now requires further study. That is my view on real-world evidence, and I'm eager to listen to Melvin and your thoughts.
Well, I think, Professor, all these different studies you mentioned is a spectrum, right? You have, on the one hand, you have all these expert opinions, and on the other hand, you have this systemic meta-analysis. They are all important, in my opinion, and they have a role to play in whatever you are trying to investigate. But the most important thing, as you say, is the quality of the studies is crucial, because it's really like garbage in, garbage out, right? If you put in a lot of different studies, but all of them are garbage, then whatever output you get is really not that good. But if you have a high quality set of different studies where, as you mentioned here, the bias and confounding are addressed, and then you can have a more scientifically robust conclusion in the end.
Yeah. So I guess we're aligned on how to use evidence. And again, for placebo, for homeopathy intervention, all of that, none of the studies is really addressing this in an appropriate way. So anyway, this is a little bit our credo here, and this is all about science and how to use science. And even a double-blind randomized study can give you wrong data, right? I mean, in the end, it is always about having high or low confidence in what you're doing. And what you see here is, again, it is a yes or no answer, and only high-quality studies should go into a decision-making process. Having said this, we come to the end. CDC confirms the first severe H5N1 case in the United States. Melvin reported about the presumptive avian flu in a poultry worker in Wisconsin, and he told you what you can do to prevent bird flu, and what one can do reasonably well in every household. I spoke about glucocorticoid use in community-acquired pneumonia, showing an increased mortality in an observational study. We reviewed non-pharmaceutical interventions in households. And again, keep in mind, this may be different from other settings where masks and hand washing probably are very well working. And finally, we showed you how we think real-world evidence should be used for decision-making. And having said this, we wish you a very Merry Christmas and a nice holiday season and a good transition to next year. We will probably be back before the next year, so I'm happy to tell you Happy New Year next time. Today is make sure you get enough of these Christmas chemistries with cinnamon, pine tree, vanilla, candy cane, joy, and let's celebrate. And we are yet ahead of 2025, but we may cover next time a little bit what we think we may expect in 2025. And I think we don't need to be too afraid. Melvin, you have the last word.
Yes, we have been afraid since the pandemic, so I think we should be less afraid now. But I just want to remind everyone, if you haven't received your flu and RSV vaccine and you know you're high risk, get your vaccine. It's still not too late for that.
Very good. Have a nice holiday. Bye-bye.
Thank you, everyone. Stay safe.